Well, today what we want to start out talking about is the complications that can arise from IV therapy. Some of it just depends on the patient's underlying condition, as well as the type of IV that they have going, the type of catheter they have in, the type of fluids. So we can break it down into flow rate problems and then actual IV equipment issues, okay? But when we're talking about flow rate problems, basically the rate is too fast or the rate is too slow. Many reasons for that. And again, whose responsibility is it to monitor IV therapy? The nurse's responsibility, right? Not the PCA, not the tech. Okay, it's the licensed nurse. So when we're looking at flow rate, it may be that the pump is not set correctly. It may be that your tubing is kinked. Maybe the position. Remember we talked about if you start an IV in over a joint, that you can not only kink the vein, but you can kink the catheter. Right? So the positioning of the arm or the extremity can have something to do with it. Maybe the height of the bag in relation to the patient. The higher that bag hangs, the faster it's going to infuse, and vice versa. Okay? So we want it above the patient. And then maybe it's just clotted off. Now the great thing about your pumps is they're going to tell you if 3/4 of these are an issue, because it's not going to run and your pump's going to alarm. Okay? Usually if there's any kind of impediment to the flow, then it's going to alarm and let you know that. There is a table in your e-book, 15.2, that talks about IV complications. Take a look at that, because you'll see complications again. Plus, you need to know it. I mean, you just need to know it. This is going to be a big part of what you're doing out there in nursing. Okay? Keep in mind, though, if you have a clotted off IV, that you do not want to irrigate that cannula, because what can happen? What happens if it's clotted off and you start trying to force something through there? You throw out clots into the circulatory system, right? Then you've got an embolus going on out there. Not good, not good. So you never want to forcefully irrigate an IV catheter. Now there are some thrombolytics that you may be asked to give in order to declot an IV catheter. But in the case of a peripheral one, you're not really going to do that a whole lot, because thrombolytics carry a lot of risk factors. Do you know what a thrombolytic is? It breaks down a clot. It's not an anticoagulant, but it actually will break down the clot. So in the case of your peripheral IVs, rather than putting the streptokinase and all that business down through there, you usually are just take it out and you start another one. Okay, now central lines may be a little bit different story, but again, that's not your call, that's the physician's. But if it's just a peripheral IV, nurses usually just take them out and start them in another place. All right. No irrigation. Now, when we're talking about other complications, you may have systemic issues. All right, this is where you're affecting the entire body. Right? Usually fluid volume excess, fluid volume deficit, and those have to do with rates, right? What kind of signs and symptoms do you have when you have a fluid volume excess? You have edema, right? What else? With fluid volume, did I say deficit or excess? What is it? Excess. All right, with excess, what do you have? You told me you've got edema. What else? JVD, right? What else? Bounding pulses. What else? What happens to your lungs? You start to have wet lung sounds, right? Crackles, those types of things, right? She said decrease. All right? What happens if you have fluid volume deficit? What do you have there? You have some tachycardia. You have what else? What else you got, Ryan? What did you tell me a minute ago? Flat veins. What about skin turgor? Okay. Inelastic skin turgor. Good. Okay. What about your blood pressure? Blood pressure, your patient is usually hypotensive. Okay. So, with your deficits, you're just going to notify your physician that that's what your assessment is showing. You know, these signs and symptoms. Okay. What do you do if you have a patient that has fluid volume excess and they've got crackles and they're short of breath and all that business? What do you do with that patient? Okay, you raise the head of the bed. Do what else? Give them oxygen. Good, good. You can, for the time being, slow the IV rate down. Okay. Depends on what's going on, but that may be an option. What if you got TPN going? Can't do that. That's not an option with TPN. Why? Because their blood sugar goes down, right? Good. Y'all were listening last week. All right. Thank God. I was concerned. Good. Okay. Of course, I'm having to pull it from you today, but that's okay. It's Monday. Okay. So when we've got patients who have the shortness of breath and those crackles and those kind of things, we put our patient up in high Fowlers. We give them some oxygen. We make them cut down their IV rate, and we contact the physician. Okay. What do you think might be ordered for your patient? Diuretics. Right. Your patient's probably going to have some diuretics. Okay, good. Now, your patient can also have electrolyte imbalances. What do you think you start to see if they have electrolyte imbalances? It depends on which one they have. All right. So let's say that I'm having issues with my potassium. Right. We're looking for dysrhythmias there. Right. Heart issues. What about my magnesium? Right. Some changes to the neuromuscular system. Right. Good. 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 So we may be asked to draw blood, check those levels. You may be giving electrolytes. Okay, you're going to give a lot of potassium out there, IV. So we want to check their vital signs. We may be, drawing, like I said, drawing blood and monitoring those things. Your patient may have an infection systemically. All right, we'll talk about some of the local complications, but they may have a systemic infection. Catheter-related blood infections are another one of those core measures and those things that that you guys are going to be monitoring out there with certain standards. That's one of the issues that we talked about with Huntsville, having the central line team, that's what they do, is take care of those central lines, because your risk of infection is certainly going to be greater if you have it in a central line. Okay, so we have to watch that. That's why aseptic technique is what we use with IV therapy. Really got to be careful when we're putting a line directly into the central circulation. Okay. You may have embolism, and it may be anything. It may be air. That's why we prime our tubing. It may be a blood clot, or it may be actually a piece of the IV cannula that breaks off, and I'll show you a picture of that here in a minute. Okay. And then your patient can always have an allergic reaction to anything we give them. Okay. So those are your systemic or body-wide type problems. You've also got some local. And these you see more often than your systemics. Okay. Because based on our assessments and all that good business that you're doing out there, we catch things most of the time before we get into, some of the overload and stuff like that. But some of these local ones, and we'll talk about these, phlebitis, infiltration, bruising, bleeding, and then, of course, infection. Okay? So let's talk about phlebitis. Phlebitis is when you've got inflammation of the vein from either a mechanical, a chemical, or a bacterial invasion, or irritation, I guess I should say. Okay. So when I say a mechanical irritation, what do you think that means? Right, that maybe the vein became very irritated because we used too big of a catheter for the vein size. Okay, maybe just our technique on IV insertion caused the irritation. If the catheter is not secured appropriately, it does move. And then you can get phlebitis just from having the IV in there too long. Chemical is from the drugs that we give them. Okay. Some of your and these are just really irritating to the vein. One of the main ones is KCl, or potassium. Potassium is very irritating to the veins, and your patients usually complain of burning when you give potassium. That's why we dilute it. What do you know about IV potassium? What can you never do with IV potassium? You can never do IV potassium by push. Ever, ever, ever. Okay? People die when you do that. Okay? So potassium is always given in an IV piggyback or in some kind of big bag. Right? Other medications that are very irritating are things like Dilantin, Valium, vancomycin, erythromycin. A lot of things can be irritating, but that's the main ones right there. Okay. And then Phenergan. Phenergan, is really bad too. Okay. All right. So this is a couple of pictures of phlebitis, and what you notice is that it is painful. Okay, it is usually red. You can see the vein itself. Okay, the vein is usually hard, very tender to palpation, and it just feels warm. That right there, you can just tell if you touch that, that's going to be just really warm to the touch. Okay. This is a little more extensive than this is. Okay. You can have oozing drainage. Okay. There you go, right there. So what do we do when we have phlebitis? The first thing that you're going to do is stop the IV. You're going to DC the IV catheter. And you need to put warm, moist compresses on the IV insertion, on the site. If it's swollen, you can elevate it. And then you're going to restart your IV in the other extremity. So this is not, you do not, and you don't need to call the physician for that. Okay, that's something that you can do as nursing interventions for this problem. Now, your patient may get some IV therapy or, some IV antibiotics or something like that. That you're going to need an order for. But we don't usually call the physician and say, hey, I'm restarting the IV because they've got some phlebitis. If you're that concerned about it, then you need to call them, okay? But, removing the IV, heat and elevating it works wonders, and then the physician can look at it when they make rounds. Again, though, if your gut tells you I need to call, I would probably notify the physician for this. Okay, that it's oozing, but I wouldn't notify them for that. Your patient may also have what we call extravasation. This is when you have a leakage of a very caustic medication into the surrounding tissues. All right. You have leakage of an irritating or a vesicant. The word is vesicant, vesicant, of a vesicant material outside of the vein and into the surrounding tissues. So the material is caustic, and as you can tell by this picture, you have very severe tissue damage. These are things like chemotherapy, some of your antihypertensives, and I'm at a loss this morning to give you one of them. Some of your potent vasoconstrictors that you may give, because what do those do? They constrict those vessels. So if it's running around out in the tissues, it's constricting those little arterioles and the little capillaries and all, and the tissue dies. So, okay, so this is something that you do not see immediately. You don't just make a round 1 hour later and this is what the hand looks like, okay? You usually will have signs that it's infiltrating, and then you immediately have to, intervene. But what happens is the patient will have complaints of pain at the site. If it is a vesicant that you're infusing, you really need to take it out, assess the situation. Okay. You have to assess to see, do they have flow? Do they have a blood return? Which means if you pull back on it, does blood come back up in the tubing? And that's a sign that you're in the vein. Okay. You're going to assess and say, do I have good blood return? Okay, and is it flowing pretty easy? If your catheter is out of the vessel, you do not get a blood return, okay, and you do not, your fluids don't just flow in really easy. Okay. So what you have to do is you have to stop the infusion and assess. You may need to aspirate back the drug. What you can, you're just trying to get any little bit out of those tissues that you can. You may actually have to inject an antidote. You put cold compresses on this one to try to decrease the pain. Okay. And this, your patient may end up needing surgery with like skin grafts. You just hook your syringe up to your IV and pull it back. So something like this, usually to get to this, you have the infiltration. The site will usually blister. You'll have a blister there. The tissue sloughs off, and then you have the necrosis. So if you're infusing something that is, has a high risk of extravasation, you have to monitor that even more carefully. Okay. There were some pretty interesting pictures on Google with extravasation. People whose whole leg, it's just gone. So, you gotta watch it. Watch it. Okay? The most common thing that you're going to see with IVs is infiltration. This is just where you've got an infusion into the tissues, but it's not a caustic material. Right. The cannula, for some reason, becomes dislodged, and the fluids are infused into the surrounding tissues, or either the vein has been perforated. No, this is not a sudden. If you puncture the vein when you're starting it, you'll know immediately because it will swell right up at the site. This is not I've started it and it's looks like this. Okay, this has been infiltrated for a little while. This one has too. If you blow the vein when you start the vein, you're going to immediately have a big. You're going to know because it's going to go. All right, and I hope you cut it off before it gets to that point. Okay, you'll see that. But these are the kind they've been infiltrated for a little while. All right. Look at the tape right there. I mean, what is the first thing you're going to do when you walk in and you see that? You're going to stop the IV, right? What is the next thing you want to do? Thank you. You got to look. Does this woman have blood flow to these fingers? She may. She may. You got to check that. All right. So if it gets to this point where that right there is happening, that's why we don't want to start IVs in people who've got rings on their fingers. All right. We take off their bracelets and all that foofy stuff. Okay. Because if it does infiltrate, you can get into that issue right there. So what you see is what you see right here. You have swelling in the extremity. Usually it is like pitting edema. You know what I mean when I say that? You push down on it and your fingerprint is left in there. Okay? You can just tell. If you smush that hand right there, you just know you're going to have a fingerprint left. Okay. Usually the area is pale. It is cool to the touch. It is usually painful. Your patient may complain that it's burning. They may complain that their skin just feels tight. And you may also notice that you've got IV fluid leaking out of the site. That's a sign right there. Okay. Yeah, you're going to take the IV out. You DC the IV. And you're going to put compresses on here. Warm or cold, doesn't really matter. I like warm because it just tends to soothe the area. Right. But there's some, question about warm versus cold with infiltration. You do want to elevate it again. And then restart it in the other extremity. You can't reuse this arm. Now keep in mind, some of your patients, this lady right here, if they're elderly and you elevate, let's say they're laying in the bed and you elevate their arm up on a pillow on them or on a pillow beside them, where's that fluid going to go? It goes right here. Okay? So then they have this big, huge elbow. Okay? So don't be alarmed by that. Just raise their whole arm. Okay? Put the pillow all the way under here. You'll see that. It's kind of strange looking. It's just that the fluid has moved. All right? But you've got to assess their circulation. Make sure that they've got good capillary refill. Okay. And then it just takes a little time for those fluids to be reabsorbed. All right. How do you think you prevent infiltration? You monitor it, monitor the site. What else? Checking your placement, right? You don't want to be occlusive with your tape, okay? Because if it can't go there, then it starts to leak out into the tissues, okay? Take your tourniquet off. Okay, take your tourniquet off. Teach your patient how to report signs of discomfort. Like I said the other day, IV therapy should not be painful. So when your patient complains of those type of issues, tingling, burning, you have to assess it. You have to assess it. You have to see, do I have blood return? Is it flowing well? And what you do is you take it off the pump and you open it up to see, does it flow? If it doesn't drip, something's keeping it from dripping. Sometimes your patients will, that can get infected, but hopefully if you've used a good technique to start it, you can just keep a bandage over it, clean the site. Once you take the IV out, clean the site, cover the site, and then just, keep a check on it. But you got to restart in the other arm. Okay. Your patient may have bruising or bleeding, hematoma formation, especially if your patient's on blood thinners. So we can get things like this from unsuccessful attempts, not holding enough pressure, or maybe not holding enough, but more not holding pressure long enough once you've been unsuccessful or once you've taken an IV out. It may be a tourniquet injury. especially for these folks who have that really fragile skin. We could put this big tight rubber band around them. Can have that. And then, of course, it can be from your anticoagulants. One of the things I learned when I first started to do IVs is that if you start an IV in the hand, or you attempt to start an IV in the hand, and it doesn't work, and you've held pressure on it, okay, if you come up here and you put that tourniquet back on again, and you're looking around up in here, you need to go back and look at that hand, because they're going to have a big blue egg right here. Okay, you've clotted it at the site, but they're still bleeding. Okay, so this is what you end up with on their hand. Just a lesson I learned. Okay, especially the folks, the elderly with the fragile veins that just pop at nothing. So you have to take it. So if you miss an IV on somebody, go to the other side. Okay? If you miss that one, then you can go back. Hopefully this one has clotted off enough that you're not going to have a goose egg, but it does happen. It does happen. Will you do this to a patient? Yes, you will. You will. You won't like it, but it does happen. It does happen. You have to hold good pressure. If it is leaking, if at the site, just dress it, put gauze on it, continue to hold pressure. Change the dressing if you need to, and just elevate the extremity again. Okay, elevate it up. You can put some ice on it. But if you have a big hematoma like this with your IV infusing, you have to stop that. Okay. And blood thinners can do that. Blood thinners can do that. If you're infusing heparin, can do that. All right. Okay. Remember we talked about embolism? Embolism is when you have some type of foreign something in the bloodstream. Okay? If you have a thrombus or a thromboembolism, that's from a clot that's rolling around in there. So your blood flow is obstructed by a clot. It's usually related to a catheter injury at the vessel site, or it may be because your catheter, your IV catheter, has not been irrigated like it needs to be and flushed. Remember we talked about PICC lines, and sometimes you have 2 lumens and 3 lumens and all that. If you're not using those, they have to be flushed every so often to keep them patent. Just like your saline locks. If you've just got a saline lock in there and you're not using it for anything, you still have to flush that about every 8 hours just to keep it patent. So if you've got a clot at the IV site, a thrombus, it's painful, it's red, swollen, the area's swollen. Kind of looks like the one that I showed you with the phlebitis, where the whole arm was red. Okay, the whole area will be red here. What we want to do is we want to stop the IV fluids. Put it in the other side. Warm soaks. Elevate. Those kind of things. Now, when we have an embolism, that means it's moving, okay? So when we have an embolus, it can be from air, it can be a blood clot, or it can be, remember I said it can be part of the catheter. you can shear off the tip of your IV catheter if you try to, I'll show you this tomorrow. If you try to advance your catheter and it won't go, if you stick the needle back in there, you can do this. You can go out the side of your catheter. That can break off, and then you've got that floating around into the bloodstream. That's not good. Okay? So you never want to take your needle out and put your needle back in. Right. Once you remove it, or even pull back a good bit, you can't push it back in there. Right. That's a no-no. So if you've got an embolus and it lands somewhere, what you have is you have a very sudden vascular collapse. Okay? Your patient becomes cyanotic. Blood pressure drops. They become very hypotensive. Rapid loss of consciousness. They get in respiratory distress. Unequal breath sounds. Because where does it land? It usually lands the lungs, right? So, sudden vascular collapse. Remember me telling you about the lady that had the orthopedic surgery? We think she had like a fat embolism, or she might have thrown a pulmonary embolism. This is what she did. She just went out suddenly. Okay. So when you have a patient who, we call it throws an embolus, you have to intervene immediately because your patient's going to die. But what you do is you DC the infusion, you put your patient in Trendelenburg. Do you know what that is? Where you put them head down and their feet are up. Okay? And I don't mean just raise their feet. I mean do the bed so the bed is diagonal. Okay? You turn them on their left side because it allows air to enter into the right atrium and disperse through the pulmonary artery. That is if you're not coding your patient. You may be coding your patient. The pulmonary artery. Mm-hmm. So Trendelenburg, give them some oxygen, turn them on their left side, and call the doctor. And somebody needs to stay with that patient. Okay. Questions about complications? Those are your main ones. Local infection is pretty much phlebitis. We'll consider that phlebitis. You can always have a superficial infection, at the site. Why do you think that happens? Unsanitary, bad technique when you started, right? I think about some of these IVs that are started like in the field by EMS. It's very hard to be very aseptic in a ditch. It really is. So what you have to watch those. They got to have the IV, but that's really not the upper part of their thought processes at that point. They just got to get the IVs in and get their patient resuscitated or fluids or whatever the reasoning is. But you have to watch that. And sometimes, I have seen IVs be started and they actually get up to the floor and they've got grass under the op site, So what do you think you do in that situation? You can discontinue it if you want to, but just undress it, clean it real well, and then you can redress it and then watch it. and then watch it. Okay, maybe that your patient's too critical for that. I don't know. You're the nurse. It's your decision. It's your decision. But it is okay just to kind of clean it, but you have to watch it. You do have to watch it. So aseptic technique, you've got to clean that site, and then you've got to stay off of that site, and that'll be the thing when you guys are checking off. That'll be the thing that you'll have the most problems with. You'll want to get all up in there. Okay, so just watch that. Be aware of that. All right, when we're documenting IV therapy, IVs really should be checked every hour. No more than every 2. And of course, if you have a vesicant infusing, you've got to check it every hour. Your policy may even say every 30 minutes. Okay. A vesicant, that caustic stuff that we talked about. Okay, we want to document the site, the infusion rate, what fluid is infusing, and how is your patient doing? What does the site look like? You're looking for redness. You're looking for swelling. Bless you. You're looking for leaking. You need to know if your IV is on a pump. Of course, we're documenting intake and output on any patient who has IV therapy should be on intake and output. And just like we talked about with the NG tubes, you're gonna at the end of your shift, you're gonna note how much IV fluids your patient has had. Okay, some places mark the bag and do all that business. That's kind of rare now because you've got pumps that tell you. So you go in at the end of your shift and you pull up on your pump how much has been infused. You write that number down and then you clear out your pump. You set it back down to 0. So when the next nurse goes in to get her IV counts, that's how much has infused since the last time you cleared it. Okay. So if I say cleared the pump, that means it cleared it back down to 0 on the counter. Okay, not the bag or anything like that, but it's done on the pump. Now, if you have an IV that is not on a pump, then you have to monitor the bag, right? Even though you may have a dial-a-flow on there, you're still going to make sure that dial-a-flow is keeping a good count of or keeping a good flow that you want, okay? So you may have a patient come to you maybe from OR, and the PACU nurse will say, you have 300 cc's to count in the IV. That means that bag has 300 milliliters in it when they left their care. Okay, so you start at that. That's your 0 point right there. Okay, when your patient, every time your patient leaves a different level of care, you need to know what their IV count is. Okay, if it's not on a pump, then you report it as you can count 300. That means there's 300 left in the bag. Okay, so when they get to your floor, they should have 300 in that bag. If it's on a pump and they're changing levels, then they just 0 it out. And they'll still tell you there's about 300 in there. You can count 300, but your pump is keeping up with it. So at the end of your shift, you're going to go in there and 0 it out and see how much has infused since you got that patient back from surgery. Okay? Yes, ma'am. she said if it takes a while from the time that she counted it to the time the patient got to you, and she said you can count 300, but by the time the patient got to you, it's 250. You still count it from 300 because that's when she did her intake was at 300. What I would be concerned with is how fast that IV flowing. Yeah. If it's open, then that's okay. But I mean, that's okay if it's supposed to be open. But there shouldn't be a huge big difference there. But you're going to count it from what she ended at. Okay. Questions about that? Okay. So intake and output's got to be done. You want to document any patient change in status at all. Okay, and you know that's common sense. Okay, and of course you want to document if there's any kind of change in the fluid or the order. Okay, especially for 24 hours. When you're troubleshooting for an IV, you want to start at the site and work back up to the pump. Okay. So look at your site. Is it red, swelling, irritated? Is it leaking? Not good if you see pus up under the tegaderm. Not good. Okay. Is it hard? Is it very sore to touch? Is it hot? Is it warm? That's not normal. And then you move on up. Does my catheter look okay? Is my tubing not kinked? Okay. And then you go on up to your pump and look, is it the right flow rate? Is my pump working correctly? Is it plugged in? When you're doing documentation on other lines, which we'll talk about toward the end, but central lines, which are lines directly into the central circulation, those dressings, documentation is still at least every hour, but you've got to be real particular with dressing changes on those, and we'll talk about those. You guys will actually check off on central line dressing changes in 201. That will be your last check off. Something to live for. Okay? You always are going to document the condition of the site, and we're changing central line tubings every 72 hours. PICC line dressings are changed about every 6 weeks, or unless they just get nasty and you can't stand it anymore. Okay, because they tend to be a little messy sometimes. We'll look at those. Peripheral IVs, we change the tubing every 72 hours, change the site every 72 to 96. And remember, guys, this is just kind of standard. Your hospital may be a little different. Okay? But for right now, let's go with 72 to 96, okay? And then you're always going to educate your patient on IV care, all right? Especially if you've got it in a place that we don't want them to bend their arm, those kind of things, okay? And to report if it hurts, swelling, those leaking, any of those issues. Some of your patients you'll find are so sensitive to IV therapy. They feel it going all the way up their arm. Okay, things just like saline. But you know what? If they feel it going all the way up their arm, it's in the vein. Okay, so here's what you say. Fabulous. That's great. That means it's where it's supposed to be. but some people are very, very sensitive to it. Questions about any of that? How about a break? You want a break? All right. Hang it. All right. The next thing that we want to talk about is venipuncture. Now, you do venipuncture when you start an IV. You puncture the vein. That's basically what you're doing. But venipuncture, in this instance, is like for blood drawing. All right. Little different technique, but not a whole lot of difference. All right. You still have to wash your hands and put your gloves on. Okay. But when we're talking about venipuncture and blood drawing, we're going for the anticubitals. You know, the other ones I said try to stay away from those. But in venipuncture, we do want to start looking at the antecubital veins there. Okay. You can draw blood from an IV when you start it. However, you have to be very careful. The reason for using the antecubital veins when you draw blood is because you're pulling blood out, and if you pull it out too fast and you don't have a really good vein, you can collapse your vein, and then you're not going to get anything out. Okay? So you can draw it from an IV. You just have to draw it a little slow. If you've got a really good vein in there, then you can use the vacutainers, and I'll show you that. But you just have to be careful. You just have to be careful. But yes, it can be done. And in fact, really, your patients like it better if you can do it that way. Okay, but you don't want to disconnect an IV, pull blood, and then reconnect your IV. You don't want to do that. All right. You want to get it on the initial start of your IV. And then blood draw after that should be done through another vein or through a different lumen if you have a dual lumen or triple lumen catheter. Okay. But plain old blood draws, we're going for the anticubitals. Okay. And most of the time you're going to be using what we call a vacutainer. And this is the vacutainer here. Okay. Your tubes, your blood collection tubes, have a suction on them. Okay, so that when your needle right here is capped, and then the other end of your needle is also capped, and you pull off that end cap, and then you screw your needle into this big plastic thing right here. The big plastic thing, I'm sure, has a name, but I don't know, right off the top of my head, I don't know what you call it. But that's reusable. Is it called the hub? Thank you, Jansel. It's called the hub, Jansel says. Thank you, sir. But you can reuse that, but you actually unsheathe the end of the needle, the blunt end, and then you screw that in, and then once you get your vein accessed, you push your tube up onto that needle here, and it sucks in blood into your tube. Okay? That's the way those work. And it's like a vacuum. And it pulls in the amount of blood that you need for that tube. The whole thing is considered a vacutainer. The needle and the hub. Okay. But you have cleaned the site just like you do for an IV puncture. Okay, either betadine, alcohol, or chloroprep. You allow it to dry. Okay, you've put your tourniquet on just like you did for an IV. Cleaned your site, and then you see this person here is holding a little traction on the vein, trying to straighten the vein out a little bit. And then they go ahead and stick. Okay. Usually with these veins you can go in, you're not trying to thread the needle in. You just want to get in there and get blood. Okay. So once you get the needle in, you kind of brace your finger here. and then you take your tube and pop your tube onto the end of the needle there. And it just automatically will start pulling up blood. You'll see this tomorrow. You'll see it tomorrow. If you need more than one tube of blood, then you take that, you're holding your vacutainer with one hand, you pull this syringe, this tube off, you pick up your next one and you slide that one on and it fills up and you can just go as long as you can go. Right? You keep your tourniquet on because it keeps that vein engorged. Okay? But once you've got all your blood that you need, pop your tourniquet, and then you're going to just use a little piece of gauze or cotton, whatever you have, hold a little pressure on it, take your needle out, and then you're going to dress it or continue to hold pressure. Y'all have had blood drawn. Y'all have seen how that works, right? Okay. You may also draw blood with a butterfly. Usually for blood drawing, we use 21 gauge needles. All right. Those tend to do less damage to the blood cells as they flow through there. But you can use, whatever size is going to be good for your patient. Your butterflies will come in, all different sizes, okay? But you're still going to access it the same way. This butterfly here has tubing on them, and you just hook your syringe up to the end of it, and then you pull back the blood that you need. You can do it that way, or somebody got really smart and put a vacutainer needle on the end of this so that you can just pop your tube on the end of it and it pulls it out. Works great. Okay. That makes it a lot easier. No. Just two ways to do it. Just two ways to do it. It could depend, too, on your, what your organization has, what kind of supplies and things your organization has. Because the ones with the vacutainer, I would think, are a lot more expensive than the ones with you pulling it back. Okay, so that's a butterfly. Let's see if this one. This shows you a blood draw here. Routine venipuncture.
This is a routine venipuncture. After locating the vein, cleanse the site with 70% alcohol isopropyl solution. Start at the site location and cleanse in a circular motion outward, not to contaminate the site. Tie the tourniquet 4 to 6 inches above the site, depending on the length of the patient's arm. Do not leave the tourniquet tied for longer than 1 minute, or it may affect lab results. Taut the skin to anchor the vein. Insert needle at a 15 to 30 degree angle with the needle bevel facing up. After insertion, compress test tube to allow blood flow into the tube. If blood does not appear in an evacuated tube upon venipuncture, slightly reposition the needle. After filling the tube completely, remove tube and rock back and forth 7 to 10 times to mix blood with the solution. Follow with additional test tubes as required. Remove tourniquet, place cotton ball over site, Remove needle and apply direct pressure to the site until bleeding stops.
Pretty simple. Pretty simple. Okay. So the thing that makes that a little tad easier is you're not trying to thread it. As soon as you get blood or you feel that you're in the vein, you can stop advancing your needle. Okay. You don't have to thread anything all the way through. Yes, it will automatically stop when the pressure equalizes in there. Yeah. There are different types of tubes that have different additives in it, you know, and they're pretty standard across the nation. The purple top tubes are usually anticoagulant for anticoagulant tests. Okay. And your blood level tests, they don't clot. Okay, they have some heparin or anticoagulants in it. Your red top tubes are usually for your electrolytes. I'm not concerned that you're able to stop that back at me. Okay. But just know that there are different tubes for different things. If you're drawing blood cultures, those are in a kind of tube that has a growth medium in it. It almost looks like a small soda bottle that has yellow fluid in it. Okay. So different types of tubes for different things. And if you don't know, ask your lab, what kind of tubes do I need for that? And on some of your nursing units, if your unit draws blood, they usually have a schematic on the wall there that if you're drawing a CBC, you need this. If you're drawing electrolytes, you need this tube. So there's all sorts of little helpful hints out there. Kind of wish you had those in nursing school, huh? Correct. And for the life of me, I think you draw the anticoagulants last. I'm not going to test you on that because I did not have a chance to look at that. I knew somebody to ask me that damn question. Yeah. It is because there is a chance that your preservatives can mix in the needle. Yeah. And I think, don't quote me on this, I should stop the integrity, but I think that you draw the anticoagulants last. Anybody draw blood in here? Is that right, Jansel? So anything with a mixture, draw those last. Okay. That's what Jansel says. That's what Jansel says. It's a very small chance, and for the life of me, I never knew that. Until I came here, and we were talking about blood drawing, and Ms. Lawless was telling me, you have to draw them in a certain. I'm like, oh no, you do not. She said, yes, you do. You're supposed to. I'm like, I've never heard that, so I learned to. So. Yeah. The Vacutainers really work wonderful because they keep a positive suction on there. So it's a really, really slim chance. If you think about, things mixing in the tube, it wouldn't be that common. But I will not ask you that on the test. I promise. If I can't give you the answer, I'm certainly not going to test you. But look at your, and if you are unsure about that, ask what, is there a certain way that you need to draw them? Okay. All right. Okay. Moving along. Nope, we're through with that. Let's move on to the next one. I said I'm through with that. There we go. Whew. Okay, for your saline locks, we talked about these the other day. Those are just IVs. Without all the tubing and fluids, these we use intermittently. sometimes you'll just have a saline lock in in case you need access. If you have a person who's having like an outpatient test, like let's say like a treadmill test, they start a saline lock on that just to give them the fluid, just to give them the medication. If it's a cardiac stress test, Cardiolite or something like that, adenosine. But then you also are using it just in case the patient starts to have chest pain or a heart attack. You've got access to their vascular system. So saline locks are really useful. They don't last quite as long because we have to make sure that they stay patent. Okay, so remember we said you're starting your IV, and then we usually connect an extension tubing or an extension set onto your saline lock or onto your IV catheter. What color is that right there? What size is that, you know? That's a 22. It's blue. All right. So you can take that right there. That's a clave, which is a type of needleless cap. You can take that and screw that onto your IV catheter and just have a saline lock. All right. That's where you access the lock and all that. But it really works great, guys, if you can use an extension tubing here, an extension set. You just have a little more play with it. Okay, remember we talked about how you can get into phlebitis and vein irritation. The more you're manipulating your IV catheter, if you're having to put your syringe and all right down here, you're manipulating it, irritating the vein. So use that if you can. It just makes life easier. And we also use these even when we're starting an IV, because a lot of times once IV fluids are DC'd, you may be ordered to leave the saline lock in or convert it to a saline lock. So in that case, all you have to do is unhook your fluids from here, and you still got a saline lock. Used to, what we do is we'd have to take the IV tubing off from right here and cap it right there. Okay, so now if you've got that, the tubing, you just unhook it right there, flush it, you're good to go. Okay. But you got to make sure that not only are you priming your IV line, but you're priming your extension set as well. So usually what we do is we put a syringe on the end of it that has saline in it, squirt saline through it to flush it, and then I just leave the syringe on the end right there and go in and start my IV, hook it up, and then I can flush it. Okay. To flush a saline lock, most of your extension sets will have a clamp on it, a slide clamp, not a roller. They don't usually have the roller clamp. They usually have what we call a little slide clamp. Okay, but you're going to clean your port, put your syringe with saline on the end, unclamp it, flush it slowly. Remember, you're just trying to make sure that it's patent and to keep it patent. Then you reclamp it and take the syringe off. That's all there is to it. Most places irrigate saline locks every 8 hours or once a shift. And we always want to flush before and after any medications that we give. Okay. So we flush them routinely or before and after any medication. You do want to flush between medications as well. Sometimes you'll go in there and you'll have 2 IV push meds. So you're going to flush before to make sure it's patent. Hook up your med, give your med, flush it, then give your next med, and then you flush it and clamp it off. You can connect an IV drip to this and infuse a piggyback, or if it's a push medication, you can push through this. Okay. All right. Y'all will give me just a second.